Can I give a brief introduction?
Sure. Okay guys, good afternoon. Please have a seat. So we have a CME conference today. Dr. Geraci is the professor of medicine in the Department of Cardiology. He's the former chair of Department of Medicine. He started academic half day in 2014. And today he's going to talk about how to give feedback, how to do evaluation. So please.
Okay. Well, thank you. For the more senior residents in the group, this is pretty similar to the talk I gave in last year's academic half day. And although it is aimed as a faculty development course, which is why it's a CME course, the information here is really applicable to anybody that has clinical learners. So interns in teaching their students, residents in teaching their interns, fellows in teaching everybody below them. Officially, I have no financial disclosures and no conflicts of interest related to this talk. So let's start off with a case, a real dilemma. It's the 4th of November. You, as the attending, are attending on the medical service. Rounds have been a struggle. The students seem to know little about their patients. The resident routinely interrupts their presentations. And the intern disappears from rounds on a regular basis for up to 15 minutes at a time. Patients and families seem lost about what's happening, and already this week there have been 3 initially stable patients that ended up critically ill without you knowing they had been struggling for several hours. Okay? So again, this is from the attending's point of view, but again, if you were the resident to find this and address it with your interns and students. So what do we do? Well, this was the most common solution that I used for many years, but actually the right one is here. All these problems can be assessed and addressed. So what are the basic principles of feedback? Or what do we want to do? We want to provide honest, accurate, detailed assessment and feedback. And this is really the most important thing I believe we do as medical educators. The data, the information, the knowledge base, so much is available at other sources on the web, textbooks, articles, different sites. But only we as instructors, we are in a position to observe, assess, and then give feedback and improvement recommendations on specific behaviors for a specific trainee. Inaccurate feedback, whether too positive or too negative, it really harms the trainee. It reinforces negative habits. It can destroy someone's confidence, even if they know they're having a problem and you tell them, oh, you're doing a great job, just read more. That's the most common assessment we get. And it does tend to deter further learning. You figure if my supervisor here is not seeing the things that I'm doing, they must not be too bad, and I guess there isn't much for me to learn here. So, and it also harms other trainees who have genuinely earned that feedback. This is related to grade inflation. I once worked at a school where a division chief told every attending in his division to give every resident and student a 9 on a scale of 1 to 9. This way, all the students and residents would like him, and they would get a good evaluation from the chairman, believe it or not. And then, of course, the trainees who have done a good job, who really earned that higher grade, this cheapens it when everybody is getting the same grade. So inflation kills economies and sometimes patients. Our goals in feedback, we want to encourage learners to identify, emphasize, and sustain their strengths. And I think if you've ever read or heard anything about giving assessments or evaluations or feedback, it says always try and start with something positive. Even if the most positive thing that you can come up with is like, I really like your new glasses, or that's a great haircut you got. But start with something. We're starting something positive, and we want to help them to identify what they are doing well and encourage them to continue to do it. We always assume at that point they've not gotten other feedback, so you are more or less assessing them de novo and don't know if another attending or another resident told them identified problems or had recommendations for them. You want to direct learners to recognize their weaknesses and accept the need to improve. Okay? If this is not achieved, all your efforts are going to fail. You can't overcome an unwillingness to learn with any sort of teaching strengths. So the idea here is you want to get the learner on the right track, realizing, hey, this could be done better, or this wasn't done well, and yes, I understand it, so I want to do it better. You want to empower your learners with an action plan. Not only do you want to get them to do these things better, to improve these behaviors, but also to give them the tools they need to do this. How can they do that? Very specific recommendations. Some things are minor and are easy for them to change. Some can be very significant and will take a lot of long-term work that may even stretch over multiple rotations, and the program director needs to get involved. But having specific actions, specific things that the learner can do to improve a specific behavior you've identified needs improvement gives them the best chance of succeeding. And of course, we want to teach the internal process of self-reflection, personal inventory, and self-initiated improvement. And I think the term that summarizes all this is personal accountability. Okay. We'll talk in a few minutes about some of the red flags where personal accountability is not present, and those are much bigger issues usually. So, written assessments. Documentation here, like everywhere, is if it's not written down, it didn't happen. So overall, it's better to be right than be liked. Tough love. Many of us have raised children or other youngsters, okay? And you're not going to pat them on the back if your 18-month-old straddles into a highway. This has not actually happened yet, but I've heard it discussed at many meetings. I think the malpractice lawyers are about a heartbeat away from actually bringing action against the training programs, possibly even the schools, if a physician, particularly if they are early out of training, performs egregious malpractice, extraordinary malpractice. And quite frankly, I'm kind of surprised that they haven't brought it forward yet, but I think it's coming. And so do a lot of other people, particularly in graduate medical education. We also have additional responsibilities here. You want those written assessments so that the other program graduates, when the program director is kind of writing their letters for future training or for jobs, they have some objective information in front of them. To our institution and our future trainees, if we're not giving good feedback and a student applying to our residency or a college student applying to our medical school finds out, gee, it's a nice place, but nobody ever tells you how you're doing or gives you any specifics, they're not likely to come. And of course, we are protecting the future patients of our graduates by doing everything we can, particularly in the assessment and feedback area, to be sure they're as competent as possible. And we also have an obligation to the public. So this is not just one-on-one. This is part of our global responsibility as medical educators, regardless of what level we're functioning on. How often, when should these written assessments be done? Well, if something really egregious happens, then that's not something you can wait till a mid-rotation or end of rotation meeting. This needs to be done right away. Something that causes patient death or injury, a major mistake that was a near miss. This is something you'd want to report to the next level up. So for an attending, it would be a program director. For a resident, it would be to your attending. And probably get something in writing. Should be communicated for residents and fellows to the program director. And again, you always want to give specifics, the event, the communication, what was told to the trainee, when, where, what happened, what they should do better. And then for final evaluations, these should be summative. Okay. If you have multiple attendings, we're all working kind of different schedules now. And some are on months, some are on 2-week blocks, some are on 15-day blocks, some are on 1-week rotations. If there are multiple supervisors over one learner's total experience, it's probably best to have a single assessment with contributions from all the supervisors. That way, all of people doing the assessment, or for instance, all the residents teaching a specific clinical clerk, can get their ideas together and give one set rather than having things branching all over the place. Because again, like here, in many other circumstances, less can be a lot more. We are now evaluating and assessing for absolute levels, not comparative levels. So saying, this is the best resident I've seen this year sounds really good, unless it's July. And you don't know, the person who's reading that might be a fellowship director, it might be the program director who's writing a letter for you to get into a job or a fellowship program. That really doesn't say very much, because you have to know what everybody else is doing. And now we have milestones and we have specific clinical competencies. So we're addressing, and we'll get to the components a bit later. But this is the way assessments are done now. We're trying to get all our learners to a specific predefined level of competence in a number of different areas before they move on. So best resident of the year, worst resident of the year, could be that same resident in July. Again, specific examples, usually, particularly if you're going to give a very high grade or a very low grade, you probably want to have more than 2 examples. Something that is, or they should be very egregious acts or really spectacular acts where they not only save the patient, but they save the hospital from a tornado and ended world hunger all at one time. And also you want to include specific improvements. This is where I think is one of the areas we lack most as medical educators. We can identify when there's problems. We have difficulties communicating that sometimes. But also, it shouldn't stop at the communication. There should be specific recommendations. So, further board preparation in the area of heart failure and valvular management. For those of you who don't know me, I'm a cardiologist, so all my examples will be cardiology. Improving knowledge in this area. Communication skills. He should specifically plan to spend 5 minutes sitting at the bedside with each of his patients before attending rounds, find out what else is going on. And also, you want to discuss these with the trainee, whether it's a student, intern, resident, or even fellow, before you send it in. So again, we'll get a little later into this, but you don't want anybody to be surprised by their final assessment, their final evaluation. Nothing, it's obviously, they'll be more upset if they're surprised because it's a lower grade than they thought they got. But even if it's higher than they thought they got, sometimes people will become somewhat suspicious about how much effort was really put into the feedback and whether their supervisor, their teacher, really has any intention on helping them grow better or just wants to get the paperwork off their desk. Okay. So where do you start? At the beginnings. Setting expectations for feedback at the start of the experience. I'm a big advocate for having something for each learner level on one printed page that you can hand them, along with the evaluation form that's going to be used to do their final assessment right at the beginning of the rotation. You set out the expectations very clear. We will round at this time every day. We'll meet at this location. I expect you to have seen your patients, done a physical, interim physical, picked up any lab results, radiology, etc., have them ready to present on rounds, which will start at 8:30 in the CCU. Okay. And in those expectations, you get more detail than that. Those are kind of performance and duty issues. Timelines are becoming more and more important, particularly as duty hours get more narrow and everybody's on different schedules and who's got to be out by 10, who's got to be out by 12, yada, yada. So, so we're all time constrained. And therefore, saying when we're going to do this and what preparation you need to have at what time, when the notes should be done, etc. It may seem like overkill, but I guarantee you, if you go a whole year where you're teaching that whole year and you don't give those specifics, you will have a number of times where some of your learners are not ready when they're supposed to be. And it's largely because you didn't make it very clear to them what your expectations were. When you're going to do scheduled assessments, and again, show them any evaluation forms, I think it's easy to print it out on paper, a blank one, attach it to that one goals and objectives sheet that you're going to hand it to everybody on your team. Include your contact information, your cell phone, your pager, that crucial statement, call me anytime if somebody gets sick, those kinds of things. And they have it in writing. Okay. So what are we trying to address with feedback? What questions are you trying to answer? Well, first of all, why are we giving the feedback? It's the quickest route to improvement. Okay, telling somebody to go home and read about heart failure is not the same as saying you really should have given much more frequent diuretics last night and that would have gotten the patient out of pulmonary edema. Saying that as soon as the patient's presented or discussed, that will stick with the learner much longer than having something put in assessment that it might be written 4 weeks later. We have a need to document problems and concerns, first as part of the tracking progress. Maybe your expectations were too high, let's say for a new intern in July or August, but in a couple of months they have achieved this skill or competent in this area, and the program director can look at these serially and say, okay, the improvement's appropriate. We have to document competence now, and you need examples to do that. I think most people who are kind of hardcore educators will think that we now, or at least profess, that we now have objective criteria for competence. Really what we have is we've broken down the subjective criteria into things with numbers, so they look objective, but the assessments are still made by an experienced individual, more experienced than the learner, who is giving their opinion of whether or not this person has reached a given level of competence. Also, having these for the PD or the APD to look at to identify larger issues. Are there patterns? Does this intern always have difficulty at the beginning of each rotation? Do they kind of decompensate when they have to take care of particularly ill patients but do well in the outpatient setting? Weaknesses or areas for improvement that may not be manifest as major problems in one setting or on one rotation, but when you see it happening time and time again, there needs to be some sort of intervention. And at times, you need to have that documentation, the groundwork for non-promotion, dismissal, or discipline. These things do happen. We try to avoid them as much as possible. But like everything, as I said earlier, you have to have documentation to both promote and decide not to promote. I think it is a tremendous way to improve your own skills as an educator. You're not born knowing how to do this. You're not trained how to do this in any great detail in medical school or in your residencies or fellowships. You'll be asked to give the evaluations, but has anybody in here ever had their evaluation critiqued by a more senior physician to say, you should have seen this, or maybe you could have stated this better? Anybody? Yeah, I don't think that has ever happened to my knowledge. So what does that mean is you're learning this pretty much on your own. You have book references, you have things you can look up, policies and protocols from the AAMC or the ACGME or ABIM. There's a lot written out there. But you as educators are not getting the feedback on your evaluations of your trainees. So each time you do this, try to learn from the experience, try to get more in-depth into the specifics of your evaluation, and next time you will do it better. I personally used to save all of my resident and student evaluations. I used to keep them in a folder so I could look over the course of the year and see if I was getting better at it. But that's all personal effort, and you're likely to need to do that also. Okay. What are we giving feedback, or what's the content of the feedback? What does it need to be structured with? Well, number one is honesty. Okay. Second is to focus on things that can change. If you're upset because your resident is too tall, there's not much they can do about that. Okay. But if it is a behavior where they have learned a bad habit or did something, not been corrected on it, and now think it's right, in fact you think it's wrong, then those are things to focus on. Remember, you're evaluating the behavior, not the individual or the personality. So you're not saying, John, all your patients are going to die unless you learn this. You're saying you really need to make sure you give enough diuretics and enough oxygen supplementation to be sure that the patient's clinically stable before you go to sleep. It's good to explain the consequences, particularly trainees that are early on, students and early interns may not realize how important some of these things are that you're trying to impress on them. So, for instance, letting them know that, we were lucky this time, but the patient could have gone in the other direction. You didn't do really anything to prevent that. And in fact, this patient could have ended up in the ICU or even worse without that attention they needed. And then the advice for future behavior. So always, here's your assessment. You need to, and recommendations. You need to look at the SpO2, chest x-ray, look at their heart rate, blood pressure, and decide from this treatment algorithm where they fall on it and how they should initiate emergent stabilization treatment. Give them very specific things to do. The last thing is limit the amount. if you tell a learner more than 4 things during one evaluation session, as you go up on that number, the number they remember become progressively less. So if you give 8 points, they'll remember none of them. And that's actually been proven in different kinds of surveys. It's better to meet with a learner several times in shorter sessions to focus on specific issues if there are a number of issues. But what they're likely to do if you have 7 or 8 issues, even say at a mid-rotation assessment meeting, is they'll walk out of there and say, oh, she hates me. That will be the conclusion, not, oh, I've got all these individual things. They'll draw this giant conclusion. Whereas if it's a couple of things that they can work on, then before the next meeting, they can actually institute those recommendations, and perhaps you can compliment them on having improved in those behaviors before you give them the longer list. When should be giving feedback? Well, the best is in real time, and it should be a continuous thing. Every opportunity you have to give feedback is there. So when a student's presenting a case to you, I would say right at the end of the case presentation, say, okay, what about this and that and this and that? These things should have been included with this kind of chief complaint. Anything that's significant. If it's exceptional performance, pat them on the back. Do it right away. Say, God, I'm so proud of you. Most interns would not have known to do this. You did that. Now look, he's ready to go home instead of heading for the ICU. They will not only appreciate that, they will videotape it and send it to their mamas. And I'm sure most of you have probably had that experience where, all training is difficult. It's challenging, it's tiring. But sometimes that one, real pat on the back, a sincere, detailed kind of acclamation of how well you did, can keep you going for a long time. But also if there are major mistakes or oversights, something that could have really hurt the patient, and that they need to know and get feedback on right away also. The more proximate the feedback is to behavior, the more likely you are to influence that behavior. Okay? Well-trained children, nobody spanks them 2 weeks after they spill the milk on the dog, right? Because the kid doesn't know what he or she did wrong. And the same can be true about trainees. You're doing so many different things, and particularly when they're on the early part of a steep learning curve. They may have had hundreds of thousands of things go through their mind in that 2-week period between when they forgot to restart the beta blockers to when they're getting the assessment where they're told they should have restarted the beta blockers. If it's a long experience, 3 or 4 weeks, there probably should be a mid-experience feedback session or assessment. Certainly if it's a month long with one attending, that's kind of a no-brainer. And you set that up with the expectation. So we'll meet at the end of the 2nd week in my office. I've got these slots available. Tell me who's available. You put it right on your phone at that point. But even if it's 2 weeks, a short assessment at the end of 1 week can still be helpful. And the advantage here is that gives you some more time to see if they actually followed up on your recommendations and made improvements. Because the best thing I think you can tell a trainee is they agreed that they had this deficiency or area improvement. They adopted these processes to improve it, and now they're doing much better. I mean, you can't say more positive things about a learner than that. And of course, at the end of the experience is the assessment. And I go back and forth with this term assessment and evaluation. Technically, individuals are assessed, programs and systems are evaluated. However, we've been saying this wrong for so many decades, I don't think we can tell anybody that we're not evaluating our trainees. So, and who are you giving feedback to? Well, the way you do it and the stage of learning they are will really dictate how you approach giving them constructive criticism. So the first is, some typical examples that are recurrent. Not all residents are created equal, especially a July 2nd year resident compared with a May 3rd year resident. Okay? They're miles and miles apart. And you have expectations that you have had for a 3rd year resident that's not really fair to have for an early 2nd year resident. You still want to help them correct that behavior. But you're going to do it in a kinder, gentler way because this is the beginning of their assessment and growth as a resident, as a supervising physician. Some trainees are more mature than others. You just have to expect that, especially now as more people are starting medical school after having done another career or having done graduate school or gotten MPH first. So not everybody is 26 years old or 25 years old coming out of the blocks when they hit their internship. For interns, some are struggling and some are high performing right out of the box. Some of this is their individual talents and abilities. Some of it is also their experiences as medical students. Also remember to give them the benefit of the doubt if they're coming from a different school rather than coming from your school. Someone who has been in the system already has a lot of advantages. They know the hospitals, they've probably done some work in the clinics, they may know the EHR pretty well already. They know people at those hospitals that they can go to find a social worker or the respiratory therapist or how to get home oxygen for a patient, things like that. Whereas somebody coming in from outside, they got to learn that from scratch. It's not standardized across hospitals. Dr. Bokus, I don't know if you're still doing this, but used to give a talk on systems-based practice to the students. And the students have no idea that the way they're seeing it is not the way it's done everywhere until they start their internship. And then there's panic time. And also late and early in the academic year. The growth and development curves vary greatly, but they're obviously steepest where there are breakpoints. So the third-year clerkships, coming out of medical school into residency, and then for fellowship, being a first-year fellow. For those of you that are fellows now or are planning on doing fellowships, your first-year fellowship you can count on as being as difficult or even more than your internship was. Because on July 30th, you're an internist. And on July 1, you're expected to be a cardiologist who can do the consults. Okay? And very few people learn that much overnight from June 30th. For students, I think one of the steepest curves is in the M3 year. It's so steep, in fact, that you can't even look at competency exams, standardized exams, and compare first rotation to fourth rotation, because they're learning so much on the other rotations as they come around. Even if what you're teaching all your students, all your medical students on their medical clerkships, the exact same thing, the first month they're going to retain and understand far less than they will later in the year after they've done some surgery or family medicine or something else where they've learned some of the basics. And with your M4s, sometimes M4s take a course, a rotation, in their fourth year because it's required. Sometimes they want it because they think it'll look good on their transcript. And those kinds of individuals are probably going to be less interested in learning the intricacies of what you're trying to teach them than somebody who's really interested in your specialty or particularly has their eyes set on a competitive subspecialty. Because they will provide the motivation. You don't have to do that. Where should be given the feedback? Well, it depends on the type of feedback. Most feedback should be given in private. If you're not sure whether it's positive or negative, do it one-on-one with the door closed. All negative feedback should be done in private with very few exceptions to that. When would you want to give feedback in front of the team? Well, maybe there's a major point that everybody needs to know, that everybody on the team is missing out on, and you're not going to critique the individual, you're really critiquing the team. So as an example of that, I've had times where my team in the CCU, nobody knew what medications their patients were on. So they were prescribed verapamil on top of a beta blocker, on top of clonidine, and then they'd be scratching their heads on why the patient has a heart rate of 36. And that I told everybody on the team because it was a critical point, and everybody was making the same mistake. So they learned at that point that it was important, and everybody was in the same boat, so nobody was singled out. If you're giving praise to the team, you guys are handling these types of patients so well. You obviously know what you're doing. You're shortening the lengths of stay. You're doing all the things that I want you to do. Absolutely give that in front of the team. They'll videotape that and send it to their grandparents and their cousins in other countries and whoever they have ever met that they want to impress, because then it's their whole team. And of course, the common error committed by the team. Okay, and how should you do this? First of all, be labeled. You would be amazed at how often feedback and assessments are given to learners explicitly, specifically, time, sitting down, and then when they get their evaluations to provide, they're asked if they got feedback, and they say, I got no feedback. I mean, I've had this happen to me, and I've always had them in the office for half an hour or an hour, gone through this all with them, and they come back and say, I don't think this is feedback. So what you want to make sure is they know it's feedback. Your learners know it's feedback. So you say, I'm now going to give you feedback on this topic. Okay, this session, this time we're going to spend is to give you feedback on what went on with this patient. Please repeat to me what you think this next 20 minutes is going to be about and what you're getting, so I know you know you're getting feedback. You laugh, but your evaluations are held in high esteem by everybody who evaluates your program. And not giving feedback is a real sin in today's day and age. I agree it should be. But it's surprising how often. You know, another example, I was interviewing all the fourth-year students that were going to do medical residencies a few years ago. And I talked to them about making career choices and things like that. And they'd come back to me, really in that session, say, boy, I wish somebody had told me this before. We don't get anything on career development. So I called Dr. Olive and I said, you know, really? I mean, we really should be doing this. He said, they have career development 1, they have career development 2, they have career development 3, they get an advisor in the first year, they get a faculty clinical mentor in the third year. And they have all these feedback loops. They get practice interviews. So they were getting all this feedback. They didn't know it. So they got asked the question and said, I haven't had any feedback at all. It's worth taking it to the extreme to be sure, at least in the learner's mind, that you're making the effort. Like anything you teach, more organization, better it's understood, better it's retained. Specifics, again, that you need to read more is a useless comment to a learner. It is absolutely useless. Everybody needs to read more. Every individual on the planet needs to read more, not just physicians. Okay? So you want to be very specific to the disease entity or the aspect of communications or professionalism or systems-based practice, whatever you are giving them feedback on, be as specific as you can. You want to come across, you want to be non-judgmental of the individual. You are judging the behavior, but having done something wrong that they didn't know was wrong does not mean that they are bad human beings or they're going to turn out to be bad doctors. And you don't want them walking out of your office or your consult room or wherever you're talking to them with that impression. But the behaviors, you are the person who's deciding if they did this right or wrong. It's your job. It should always be face-to-face. Okay, emails, we've gotten way too addicted to emails. Emails can be very misleading. You know what happens if you leave the cap lock on. Somebody will put a hit out on you for screaming at them. So they should be face-to-face. And you should supply writing, particularly in the interim if there's anything that's really major, but also at the midpoint and final assessments. So in summary, feedback essentials. Feedback should be labeled, should be timely to the event that's being assessed, should be honest, must be honest, has to be honest, no matter how uncomfortable it makes you. This is the tough love that we've signed up to do. Should be non-judgmental of the individual, should be well organized, specific, limited in scope, so you're not doing 10 or 12 issues at one time. Focus on items that are changeable and be well documented. So here's an example of good feedback. Mary, I'm going to give you feedback on your work on this patient. I would have put in there, Mary, you're going to get some feedback now. Mary, do you understand that this is feedback? And then maybe have her sign something saying, yes, I'm receiving feedback this time, this date. You did well to recognize that this was pneumonia and sepsis. However, you should have given bolus of saline and antibiotics immediately instead of waiting for your other labs to be drawn. Learn from this now and you'll save many people's lives in your career. So here you're getting very specific. You're starting off with something positive, but there was a specific behavior that could have been detrimental to the patient. So rather than waiting for the hemoglobin A1C or whatever else to come back before treating, get your cultures off and start your antibiotics. And that can be the difference. You know, one of the big determinants of survival in sepsis is how soon the correct antibiotics are administered. It's one of the few things that we can actually influence in there. And here's an example of bad feedback. I hope most of you have gotten some good feedback, but I'm sure all of you have gotten some bad feedback. So Jason, your presentations have been okay. Every now and then you might miss a thing or two, but overall they've been pretty good compared to most interns. What does that mean? Nobody knows what it means, especially the learner doesn't know what it means. And this is one of those types of feedback that will strongly reinforce negative behaviors. If they come across net positive and you haven't given them any specifics they need to improve on, what conclusion would you make if you were that individual? I guess everything I'm doing is right. So, I'll keep doing brain biopsies at the bedside. No, nobody told me it's wrong. And that's, of course, how we learn a lot of things. You never are taught all you need to know in preparation for your residency or fellowship training. So you're still learning things on the fly as you go along, and some of it is trial and error. We encourage people to ask questions, but you'll hit 1,000 things on the first day that you may not know exactly what to do. And you're probably not going to want to ask your resident or your attending all 1,000 of those things. So you're going to try what you think is best. If you don't get feedback, if that was done incorrectly, you've now established a behavior that you will continue that is detrimental to the patients. Okay, so we went over what to do, how to do it, when it's needed, why it's important. Why aren't we doing this? This is a little chart I think was at a presentation at one of the AIM meetings several years ago, but it was very good. It was done by a program director at a very large residency. So why aren't we doing it? Well, the evaluators may be worried about upsetting the learner. That's pretty common. We've already addressed learners not recalling the feedback. That is fixable if you're just willing to repeat things enough and have them sign their name and perhaps stamp their hand, something. Acknowledge that there may be gender bias. If you're new to the evaluation process, it might not be a bad idea to meet with one of your peers, one of your colleagues at your level of the opposite sex, and say, I've got this trainee that I need to express to them how, they're not performing well in the patient communication part. But I want to make it very constructive sounding. This is what I'm planning to say. How do you think that would fit with a female resident or a male resident if you're a female attending or intern? And just get their feedback on it. Certainly, different sexes do receive feedback differently, but there's a spectrum across the way. So you can't make assumptions that all women will hear something one way and all men will hear something another way. What you want to do is make every effort to make the feedback you're giving being as constructive as possible. So you try to avoid as much as possible anything that would be seen as a negative indicator and would shut the learner down from hearing anything else. Sometimes the feedback is too soft. We've learned about that and seen an example. There's nothing wrong with planning, rehearsing, and actually rehearsing your feedback. Maybe you even want to have notes you want to refer to when you're meeting with them individually. Or if the feedback's too general, read more. And there are suggestions here on potential approaches to it. But I think the most important thing is to realize that all of us, especially when we're beginning out, face each of these barriers and many more to a greater or lesser degree. We're all dealing with the same thing, and how we solve that may be very different. I think being attentive to your role as an evaluator and committing yourself to getting better at it as you go further in your career is a good start. And then these are some tools that are available and things to watch out for. So, what tools can we give you? Well, a little book, been around for about 20 years now, I think, the 1 Minute Manager. This is a business book, but it is very good in, the principles there are adopted in a lot of education texts and programs. So it tells you about 1 minute praising. So translating this to the clinical settings, how would you do this? So this is right after something has happened, short, you pull the intern or the medical student aside. First, you start off by reiterating the expectations. Remember, I told you in the beginning, it's really important that you know all the medications your patient's getting in the hospital. Then praise immediately. Obviously, you picked up that there could have been a disease-drug interaction or a drug-drug interaction, giving that drug as first line, and you advised against it. That was right. That was terrific. You should always be thinking about drug interactions as patients are on more and more medications, particularly when you can't figure out what's going wrong, when something new happens and doesn't fit with whatever else was going on with the patient. Pile it on. This was great. I'm so happy that you were thinking about these things and taking this kind of global approach to your patient. I'm really happy about it. The pregnant pause, which is most business books have this incorporated in it. I don't think most of us do this. Letting it sink in a little bit, then give more encouragement and shake hands. Okay? Now, this is easy to do for most people. This is an organizational strata. Make sure you're hitting all the high points. This is a little bit more difficult. You start the same way. You reiterate those expectations. Told you at the beginning, one of the things I wanted you to all know is all the drugs your patients are on. Critique it immediately. Again, as proximate to the behavior as you possibly can. And say what was wrong. Be specific and what the right thing was. So before prescribing a new antihypertensive drug, you should have reviewed all the drugs that the patient's on and be sure there wasn't going to be an additive negative effect or an interaction or something else that could be potentially detrimental to the patient. And you can't pull punches here. You don't want to be judgmental of the individual. But that was a bad thing, giving a big dose of verapamil to somebody who's on 400 milligrams of metoprolol all day. And then them running to you and questioning, I don't know why he's so bradycardic, he won't wake up. You got to make sure they understand that this was a wrong thing. It needs to not happen again. Pregnant pause. Shake hands again. Okay? That contact, assuring them that you still value that person as a team member, but you're here to make them better doctors. You're here to help them become the best doctors they can. And that's what part of this process is. And that shaking hands and reminding them of the value is a really good way to do that. It doesn't take long. It's pretty easy. Everybody will appreciate it. And then you want to reaffirm this whole thing. You're here to learn. Everybody makes mistakes. It's important that you not make the same mistake twice. You understand that this was wrong, this was the right thing to do, and then forget it. Don't ever bring it up again unless that same behavior is repeated. Most of you have probably been told of something fairly specific that you need to do differently. That was probably in your mind for the rest of that rotation, at least. You want to make sure you never do that again. But even though you may never do it again, or you haven't done it again, you really don't want to hear about it again. You got the message. You're doing it right. You're taking every opportunity to do that. There are other things that you can be critiqued on that would be more beneficial for you. Okay, finally, the full evaluations or assessments. Here you're giving, like this is an end of rotation assessment, you're trying to provide a complete view. And one system that's been developed for this is called the grade process. It's an approach to getting rotation assessments to be valuable to the learners and be valuable to the program directors who are assessing progressive improvement in competence and learning. The GC stands for getting ready. Okay, it will be many, many years, if you go into academic medicine, it will be many years before you're ready to do this on the fly for all your residents. Reviewing expectations with the learner, making your assessment, discussing the assessment with the learner, and ending with the grade. So in more detail, what's involved in getting ready, review the course rotation expectations and the evaluation forms. Said this in the beginning. Make sure that everyone knows what's expected of them. Articulate those expectations to the learner. That's why I think having them in writing is so helpful. But you also want to articulate them verbally and reinforce that. Maybe go through that one-page summary of expectations with them, in person as a group, so there's no questions. Schedule that end of experience evaluation. Don't say, I'll meet with you sometime at the end of the month. Sit down, get out your electronic calendar and say, okay, I have time on the last Friday of the month at 1 o'clock, 1:30, 2 o'clock. Which one do you want? Get it locked in right then and there so they know when it's going to be. And obviously, you want to make sure you're not getting any interruptions, if at all possible, during that time as the evaluator. You want to have your attention focused on the learner. So this is some feedback that an attending wanted to give to a fellow, I think. Jim, you must call me anytime someone on your service dies or is transferred to the ICU while you're on duty, no matter what time of day or night. This is something that obviously should have been made explicit in the expectations. I think we're doing a better job of that now. We have kind of required calls to attendings. But this was the case forever. And it's always very disheartening to come in the next day as a supervising resident or fellow or attending and find a patient or two that you thought were doing real well, and now they're in ICU and somebody's talking about hospice care. So specific, conforming to the expectations, articulated, and during the end of rotation evaluation. Going through the expectations. Part of what you do also in the beginning is you are trying to determine what level your learners are operating on. And we went through some of the reasons on how your feedback should be different to different individuals depending upon their personality type or their stage of training or even time in that academic year. But your expectations are going to be different, and you might want to even express that to some of the learners at the beginning. Look, I know you're a senior student. I know you're headed for an OBGYN residency. I want you to focus on the things and learn about the things that are going to be relevant to your eventual practice. So we will look at, I want you to learn pre-op clearances very well. I want you to learn about managing medical issues in pregnant patients that we will see in consultation. I want you to know what drugs can't be given to a pregnant patient. Things that you know are going to be particularly relevant to their future plans. And that will get them more on board, certainly, and increase their knowledge. But they may not be starting with, they may have been thinking OBGYN since the beginning of third year and may not have just paid as much attention in the other clerkships and rotations. Reviewing the goals, your program's goals, and the learner's goals. Very easy way to do this, motherhood and apple pie. The program is designed and administered to try and make you the best physician you can possibly be and make you competent in all areas. My goal for you during this month is for you to learn as much about this topic as you possibly can to develop your communication skills, to get efficient in your practice, and to get good documentation down. And you can ask them what their goals are, or you can tell them what you think their goals are or should be, but then you get feedback from them. So I'm assuming that you're here, that you want to learn everything you can, and that you're devoting your time and your effort to becoming a better physician. Is that right, Jim? And if Jim says, nah, not really, it's just required, then you don't have to waste too much time with Jim. Describe the evaluation process, as you said, so here's an example. Rachel, have you ever managed patients with heart failure overnight in the hospital? Do you feel competent, comfortable with this role? Tell me how you're going to do this. How are you going to manage this patient? What do you think are the critical decisions? This is bringing the expectations down to some very specifics, and you can do that additionally when, for instance, you know this trainee is going to be managing a particular patient and the trainee may not have much experience with that patient. A lot of times we know it's being admitted from the clinics. They got decompensated heart failure. And maybe your new intern, even though they'll have a resident backing them up, but the new intern may have never been primarily responsible for managing a patient with that particular disorder and that acuity. So it's really good to do it ahead of time. And what do you think about this? What do you think about that? Kind of arm them, prepare them in advance, and then the next day you can give them feedback. Say that was done really well, or you did almost everything right. Probably should have given more diuretics, or you probably should have started some dobutamine or something like that. But it's part of a system that they understand. They've learned a lot from your preparation, and then the feedback will be even more important. Now your assessment, observe, record, provide it regularly. Having learners self-assess, a lot of people propose this. I found this to be difficult for a lot of learners. A number of learners think they're doing much better than they actually are. Some learners are too modest or underestimate themselves and actually think they're doing a lot worse than they really are. But everybody has developed kind of a self-image of how they are as a physician at that point in their training, whether they're a medical student or trainee. And finding out that self-image may need to be changed is a big challenge for a lot of people. So there's a potential for having learners self-assess as having a negative effect, although in general it's proposed as having a positive effect. If you ever get anything like this on a board exam, the right answer is have the learner self-assess and then compare your assessment with theirs. But it's a way to do it. You can do it informally in discussion, or you can even do it in writing. So Tim, how do you think you did managing this patient? What would or will you do differently next time? What could you have done better? This is the continuous improvement that we're all striving to do. Discuss the assessment with them. Make it a formal meeting. This again, if you're going to have your learner self-assess, then you both should fill out the forms and then compare them together. Well, I thought you did this well in this. You think you did better. Give me some examples that would justify a higher grade or better competency in this area. To discuss those differences wherever they were. So Beth, how do you think you did this month? Tell me what you think you could have done better. What did you learn? What do you still need to learn about the types of patients that we took care of this month? Okay. And then you're ending with a grade. You have a completed evaluation form. You should have supported all your assessments with examples. And if you're ever giving an exceptionally high or exceptionally low grade, and exceptionally low for you may be a 6 out of 9, then you want to have examples. And probably for exceptional grades, it should be more than 2 examples. The behavior should have been repeated and identified as a real problem or a real asset, that they're, aspirational and, God's greatest gift to the world, or they really should be wearing stripes and locked up after 10 o'clock. So, giving them specifics on why you gave that grade, and it's because this, and this, and this, considered to be lack of communication skills, and therefore I can't rate you as competent without supervision in this area. Okay, a couple things that I've added. There are some things that you can't fix on a rotation, no matter how much you want to try. We as physicians are all supposed to be reflective. We're supposed to be trying to constantly improve our practice and to be accountable for what we do. There is, I think, no better concise statement about our professionalism than these 2 lines. But you want to watch out for red flags. And these are learners who fail to acknowledge that their actions were wrong or inappropriate. Okay? Just saying, no, I think this is the right thing to do. I like phlebotomy for treating heart failure, and I'm going to keep taking 3 units out of everybody who comes in with pulmonary edema. If they regularly place blame on others for their actions. Oh, the nurse gave me the wrong thing. She didn't tell me. Oh, my intern didn't tell me this. My student was supposed to follow up on that. I'll have to get after that student. Somebody you're going to have a very hard time fixing. Because they're usually signs of underlying personality disorders that started way before your rotation. Or if they demonstrate broad disrespect for other healthcare team members. As you all know, healthcare is a team sport now. It has been for a while. It will become more so in the future. And that social worker or that physical therapist may be just as important to that patient's recovery as what you do as a physician in prescribing medications or communicating prognosis or whatever. Everybody has an important contribution. And your patients will not do as well if those other health professionals are not making those contributions to your patient's care. So you spot an individual, a trainee at whatever level, who's saying, oh, what I have to deal with those social workers, those respiratory therapists are idiots, the nurses just want to keep me up at night. That's somebody that has a kind of systemic problem. Or if this is probably the worst, they try to cover up their errors. They change records, delete reports, change accounts of events. This may actually be a crime if they change the official medical record. It's become much harder to do now with the EHR, but I am told those that are adept at computer skills can still find ways to do it. It is absolutely Medicare fraud if it's a Medicare patient, if there's any alterations made to the chart previous to that. And particularly, there may be some explanations for the first 3 here that they had some sort of specific experience, but going back and covering up errors is never an acceptable behavior. It really should be grounds for dismissal from a program. Okay, so the last few minutes we're going to spend on competency-based education, what we're trying to deliver and how we assess it. This RHYME framework was developed by the AAMC, I believe, many years ago, and this is tied to competency. So in each of the areas where we're evaluating a learner, what level will we put them at? Are they a reporter, interpreter, manager, or educator? Generally, our third-year students or clerks, specifically early in their rotation, we want them to be good reporters. We want them to consistently collect the appropriate data, present it in an organized way, accurate, and timely. The next stage up would be an interpreter, taking that data, whether they collected it or not, and formulating it into a problem list, potential diagnosis, justifying a differential diagnosis. So this is kind of what you see in the Step 2 CS exams, certainly what you would expect of a senior resident or a senior medical student to do this, and probably, and certainly an intern being able to come up with their independent initial differential. The manager is the one who takes that differential list that's well substantiated and then plans out, gives you a plan of appropriate diagnostic and therapeutic procedures. So certainly an intern at the end of their internship should be functioning at this level, ready to become a resident. Okay, a manager, you have to be at least a manager to go on to be a supervisor, definitive supervisor of a learner. If you're not doing that, then you probably need to reinforce your skills before moving on. And then an educator is the one that does all of that and then has found a way to effectively convey it to both patients and colleagues to convey their knowledge, their reasoning, and their analytic skills. Hopefully, most of your teachers are at this level, but a lot of you, and particularly in your senior years as residents or in second or third years of fellowship, will get to this point and can be very effective teachers, even more globally than just at the bedside. You know, the competency milestones at one end of the extreme, they can't get this done even with direct supervision. You're standing right next to them, telling them what to do, they still can't do it. Second, they can do it with direct supervision, so you tell them what to do and they do it, and then you tell them what else to do and they do it. Third one is they can do it with indirect supervision, so you've kind of told them what to do, but you're not there, they do it, and then they report back to you that there were no complications if it's a procedure. Able to function independently, and this is the level everybody who's completing a program should get to in all their competencies. You should be able, whatever those competencies are for whatever program you're in, residency or a fellowship, even at the graduating from medical school level, you want to get each individual to a point where they can function independently in that area. It doesn't mean that any intern, maybe no interns, are going to be at a fourth milestone at the end of their internship. It's a 3-year program for a reason. Okay? But before they're signing up to take their boards, they need, and going out into practice or going on to another training program, this is what we shoot for. And the term aspirational, originally it was meant to be as unusual as it sounds. And unfortunately, it has suffered from grade inflation also. So now we get a lot of people that are aspirational at the beginning of their second year. My definition of aspirational is if they can do what I'm doing better than I can, then you're aspirational. Okay. It was intended to be maybe a top 1% when this was set up. And what we've done is a lot of people have translated in that, well, I used to give a lot of 9s on a 1 to 9 scale, so I guess I'll give a lot of aspirationals now. But it really is an extreme. I very rarely would give this to anyone. Maybe a third year at the end of the year if they are really essentially functioning as attendings, whether in a subspecialty or general medicine. And they are really ready, say it's April or May, to assume that attending role. Those individuals might be aspirational. But if not, I think too much of this is clogging up what was intended by this and to allow the really exceptional individuals to shine, but making sure everyone is a competent provider. So in summary, we'll talk about feedback and assessments. The characteristics of effective feedback we summarized earlier. It should be labeled, timely, honest, non-judgmental of the individual, well-organized, specific, limited to a couple of specific things per session, focus on items that are changeable, and documented. Okay? Good feedback should have all of these characteristics, not just some of them. Effective assessments, so these are the end of rotation or mid-rotation evaluations. Refer back to the expectations that they were given at the beginning of the experience. Again, be honest, deliver it face-to-face first. You don't want anybody being surprised at the grade they got. I've experienced that in my career, and I'll tell you, it's not something you want to have to face. It's very unfair to the learner also. Write it out, give specific examples, always provide advice on how they can improve. That's the feedback that most people want. They want to know, okay, they may even know, I already did this wrong, but I don't know how to do it any better. So those specifics are one of improvement, how they can improve. It's probably the most important part of an official assessment. And obviously you want to refer to the competencies, so you're making this as objective as you can. Admittedly, these are still subjective assessments, but the competencies are something that everybody has to accept because they're ACGME or LCME required. And if you don't adhere to them, then you cannot be certified by that organization. So this is our case from earlier. If you remember, rounds were bad, students weren't doing anything, the intern was disappearing, we never figured out where he went. Families are unhappy, and every time you walk in, there's 2 more patients in the ICU. So at the end of rotation, it's now your last day on the rotation. After establishing expectations, setting goals with the team on the 4th, which is when the last summary was written, the resident was communicative with you and allowed others on the team to grow. The team responded well to immediate feedback, and rounds were focused, with patients prioritized and all team members contributing to the discussions. The intern and students began committing independently to an assessment and plan and to explain why, to defend their decisions. Mid-month feedback was fruitful and did not surprise anyone. Key concept. Patient care was busy and tiring at times, but rewarding and fun. So a lot of specific things we discussed earlier are brought out into what actions this attending took early in the month to rectify some of the problems, and they are highlighted here. If you want to read more about this, these are two of the best books I know. They're 2008 publications from American College of Physicians. They're available either individually as part of a set on medical education, and even though they're already 8 years old, a lot of the stuff in there has not changed. So they're very good, concise references. Wrapping up, it really is, feedback and evaluations assessment really is the most important thing we do. It's the one part of learning that the learners cannot get from anyone except us. And if we are going to be educators in whatever role we're on, as a resident, as a fellow, or even as a teaching attending or a full-time faculty, investing in developing those skills is probably one of the most important things we can do to become better educators. Okay. Now, we don't have time, obviously, to go through these. I didn't intend to, but if you look at the slide sets that will be posted, there are about 5 scenarios. Each one are in 3 stages, kind of by time. So if you're interested in going through them, read the first page, answer those questions before going on to the second and the third. And they cover a lot of the common issues, but also display a lot of the actions that we talked about here. Okay, it's 1 o'clock, so we're done. I'll be happy to take any questions. If not, thank you for your attention.